This is one presentation which I had given at a meeting at Hind Medical College, and it was a PG program in which postgraduate students of ophthalmology were involved, who were supposed to be having some talk on phacoemulsification and other methods of cataract surgery, and as well as introduction to phacoemulsification, not only as a theoretical part but a live surgery also. So I performed a live surgery on a patient with grade 5 cataract doing primary horizontal chop. So when we talk about surgical management of cataract, I put forward these two images. One is a conventional feature phone and other is the smartphone. So as we all are aware that these both devices can do the same basic task of making a call and communicating to the world and also take photographs, but still smartphone has its own value added features which we all prefer to use. Similarly, when we talk about management of cataract, we have surgical options, and one of them is phacoemulsification, which is like this smartphone, and it has features which make it more appealing to the parents, patients, and the surgeon as well. So, what is the advantage with phacoemulsification? The one advantage is that it is very popular among the patients and doctors alike, and this is the biggest advantage. Rest of the features are just fallout of finer points, but ultimately they culminate into this feature that it is very popular. So it has a closed chamber technique, a minuscule incision size, massive support from pharma industry in a form that you have foldable, rollable IOLs which are available in all variety of optics, and there is no patch and there is no injection needed if it is done under topical anesthesia, which is very much possible for phacoemulsification. Now when it comes to the disadvantages, it is relatively expensive and it has few contraindications where rest of the techniques come into play. So it's a part of the history just to sensitize ourselves so as to know that how this technique has evolved over a period of time. So this was an epic journey, and there's a paradigm shift in the management of cataract, and it was initiated by Dr. Charles D. Kellman, and he was an American citizen, and he was a resident in ophthalmology at Wills Eye Hospital, and he was very much impressed with the scaling machine which his dentist friend was using to scale the plaques on the dental surface, and he took that idea and conceived this machine which is seen here in a picture, and this is the earliest possible phaco machine which he designed and used to extract cataract. Over a period of time, evolution of phacoemulsification has occurred, and these are the prominent landmarks which I would like to mention here, which played a role in making the phacoemulsification a preferred choice. So the time of the surgery has reduced from about 70 minutes to 10 minutes, and this is all because of continuous evolution of surgical techniques, and of course the skill of the surgeon is also involved with the similar pace. The incision size has reduced from 6 plus millimeter to 2.4 to 2 millimeters, and this is not only it sounds good, but it also gives an opportunity for a very stable incision which doesn't need sutures and a rapid healing and rehabilitation time. With the advent of technology coming into the manufacturing of the phaco machines, we have features which have enhanced the safety and functionality of the machines, and we expect that more of these features will be added with time. Now, in recent times, we all have heard about femtosecond laser, which has increased the accuracy of the sizing and the repeatability of the incision and capsular excess, which has enhanced, although it has not stood the test of time. And ultimately, reports are there which say that there is actually no difference in the outcome of the patients who are operated using femtosecond laser and routine phacoemulsification surgery. Those people who are unable to perform a good rhexis, we have now capsulotomy devices which can perform a good rhexis. But there's a irony with these devices that we can see that these tools are more useful for those surgeons who cannot do a very consistent and regular capsulorhexis. But unfortunately, these are those surgeons who are less experienced and at the same time they have less capital to invest. So they may not be affluent enough to afford these new tools. And at the same time, those surgeons who are good at having some capital to invest are usually those surgeons who have evolved over a period of time and they are already very good at capsulorhexis, so they may not need these devices. But overall, these are few milestones which I would like to mention with the progression in the phacoemulsification technique. When it comes to evolution of phacoemulsification, one major effect is the use of topical anesthesia, and this was first reported by Kirshner in 1993, and this has really changed the perception of a patient undergoing cataract surgery. And the earlier things which I mentioned were actually something which you can talk about in conferences. You can talk with a patient, impressing him about the technique used, the laser used. But this use of topical anesthesia is something which has made a difference in how the patient experience goes on during the surgery. It is safe, it is painless, there is a minimal handicap because rest of the motor functions of the lid and eye are maintained. So there is no need to patch the eye because the lids are functioning, and there is an immediate visual recovery. And these features have made this a magical experience for our patient. So patient goes into the OT and gets operated, takes about 10 to 15 minutes of time, and when he is out he can actually see better. And this is something like a magic because even a refraction and dispensing of glasses will need at least a day. And here we have a situation where the patient undergoes a transformation in his visual experience just within a period of 10 to 15 minutes. So this is possible with use of these all medications which enhance the experience, make it painless, and also enhance the safety. So one can use these medications which are like proparacaine, this is eye drop, then you can have lignocaine jelly which has a longer retention time and so deepens anesthesia, then you have lignocaine solution, and then you can have this device, this injection which can be injected into the anterior chamber, and this will provide not only anesthesia to the inner delicate tissue of the eye but also enhance the pupillary mydriasis. One added feature of phacoemulsification has been clear corneal incision. So unlike other incisions, clear corneal incision is straightforward, and as you can see that you simply place your blade at the right point, and this takes hardly 10 seconds to make an incision, unlike scleral tunnel where you have to dissect the conjunctiva and then cauterize the blood vessels and then dissect. So it is swift. It is doesn't involve any unsightly conjunctival bleed. We can see that here because no other instrument is needed and just blade right the right position does the job. These incisions are self-sealing, there is no conjunctival abnormality or irregularity, so there is no post-operative discomfort or irritation. And this can be used also for reducing the corneal astigmatism if it is placed in the steep axis. Evolution of phacoemulsification has been supported by pharma industry, and we have now foldable IOLs which can be implanted through these small incisions, and this is one such demonstration that the IOL which goes inside simply folds and unfolds when it gets the space, and they are affordable now, and we have all variety of IOL, aspheric, extended depth of focus, bifocal, trifocal and toric, and there are IOLs which can be easily implanted through sub 2.8 mm incision. So now coming to the basic of the phacoemulsification, what does it consist of? So phacoemulsification is basically a device, a machine which provides you irrigation. It provides you a pump which can pull out fluid into the dustbin, and this fluid exchange will happen at the tip of the phaco probe, and the fluid circulation will occur inside the anterior chamber, and this will help in flushing out the contents which need to be removed from the eye. And this all is materialized with the phaco probe, which itself is an electronic device which provides ultrasound frequency vibration which act like a hammer which break the formed nucleus, and this all is controlled by a foot switch which can be programmed to have various functions, but basically irrigation, aspiration and provision of providing power or ultrasound to the phaco tip, which can be changed with the amount of press of the switch. So there are a few things involved like fluidics, which involves the inflow, which is usually gravity based, and a positive pressure system is also used nowadays in advanced machine, where you have a collapsible pouch which is kept in a compressed chamber, where the amount of pressure applied on the pouch will decide the outflow, and this can actually regulate the intraocular pressure very tightly, and this will provide a very fine tuned control of the intraocular pressure. There is an outflow which can occur because of the aspiration pump itself, so the pump will draw out fluid, and also there is some leakage which also adds to the outflow, and this should be balanced between the inflow and outflow so that the anterior chamber is well inflated and there is no collapse, because that is going to cause problems. So then comes the concept of surge. So here we have a video where you can see that during emulsification, if the inflow is not in tune with the outflow and it is less, this can cause negative pressure inside the anterior chamber and cause collapse of the chamber, and we will see that. So the moment this happens, the anterior chamber of the eye will simply collapse, and you see this is what is happening now. So this is a situation which is to be avoided, and machines are well equipped to avoid this situation. And this usually occurs whenever there is a break of the occlusion, because the negative pressure inside the aspiration line can cause collapse of the tube, and when the occlusion breaks, this collapsed tube is going to regain its composure and the size, so the fluid is drawn out more, so what outflow, that is the aspiration outflow and the leakage was happening. So now there is an imbalance between inflow, and now the outflow is divided into three. One is that tube which is going to regain its caliber, so it is also pulling out fluid, and then the regular two outflows, which is leakage and the aspiration outflow. So this is something which should be avoided, and this is something which the machines are equipped to deal with. Another thing which is important is ultrasound power, which is delivered using silicon or quartz crystal, which we all know that when alternating current is applied over the quartz crystal, it causes it vibrates if it's alternating current, and this crystals is used to provide the driving force of the vibration of the tip, and this is known as stroke length. The anteroposterior excursion of the phaco tip is known as stroke length, and you can have the phaco probe tip, which can be a 0 degree, 15 degree, 30 degree, and so on. And the difference between them is that the 60 degree will have maximum sharpness or cutting power, and 0 degree will have maximum holding power. So there's usually something like a balance between them, so you usually use 30 degree or 45 degree tip. Then you have ultrasound power, which can be modulated in a fashion that it can be delivered in a linear ultrasound, so that the tip is vibrating to and fro like this, and also it can provide rotation. So this is, some machines are providing oscill or oscillatory motion, some are providing translatory motion, but this also provides one more axis of vibration of the tip, which can aid in consumption and phacoemulsification of the pieces more efficiently with less heat generation. Now, ultrasound power can be modulated in a way that we can look at this graph, that you have on cycle, which is here, and off cycle, and this can be 50% time it is on and 50% of the time it is off. But the phaco power is known to have repulsion effect of the phacoemulsification process, and the pieces which are floating in the anterior chamber aqueous cavity may actually get repulsed with the continuous phaco power. So you have off cycle, which improve the aspiration and magnetic followability of these pieces, and it also provides cooling of the tip. So we can have now situation where you can turn this 50% duty cycle into various percentages, so that you can reduce it or increase it as desired, so as to fine tune the amount of energy delivered, and at the same time not compromising with the cutting capability. So all this is about the very basic of ultrasound or phacoemulsification machines, and there are various techniques which are popular, and that can be another session, but right now we are done with the basic of phacoemulsification. Thank you.